there's a landline number, and I'll ring her quickly on
Morning. Ryan Robson, the Executive Clinical Director at Healthcare Improvement Scotland, and welcome to this, the first in our 2015 series of QI Connect. This series came from a request from our national clinical leads here at Healthcare Improvement Scotland to connect frontline clinicians interested in quality improvement with international leaders in the field of improvement. We ask that we make the sessions short, accessible and recorded to allow access at a time that suited them. We've used this technique throughout 2014, and many of you will have joined us for that series. I know we use WebEx as the medium. I'm going to hand you over to Jennifer now, who's going to explain to you a little bit more about using WebEx for today's call. Jennifer.
Thanks, Brian, and welcome to everyone on the call. Just a couple of housekeeping slides to get started. If you could please use the chat function to see the right-hand side of the screen communicate, and I'll talk you through this just in a moment. If you're having any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, then please message the event manager using the chat function or call number that you see on the screen. On the side of the screen, you should be able to see a list of everyone who has joined this call. If you make a comment or join the conversation in the chat box, please select all participants from the drop-down screen. From the join list, circled red on the slide, type message and then send. Then we would really be able to like to be able to identify where participants are dialing in from. So please help us to do this by clicking on the blue arrow on the top left-hand corner of your screen as circled on this slide. And then just please click on the location that you're dialing in from. No problems with this?
Well, that's our first glitch of the technology. So not to worry, we'll get that sorted for the next episode of QI Connect. Jennifer. Now, we have a whole series of partners who've joined us for today's call. We're absolutely delighted to say that we've reached more than 202 organisations joining in with the call today, which we're absolutely delighted with. And their logos are included in these slides. It has been an astounding success that so many organisations have signed up. In fact, today we have a record of more than 250 individuals signed up for the call. We're absolutely delighted with that. And I shall mention again to many of our academic partners, we're delighted to have more than 20 universities joining the calls, including three new universities, King's College London, Queen's University Belfast, and the University of Aberdeen. Absolutely delighted and welcome to the call. And the three new organisations today as well. We've got Blackpool Teaching Hospitals, Bolton Clinical Commissioning Group, and the Countess of Chester Hospital. Thank you very much for joining us. As you know, we've got an amazing global reach with this programme. We would now reached 42 countries signing in, and we're absolutely delighted with that. We're pleased to partner with other quality improvement organisations across the world, including ISQA, and ISQA continues with the 2015 series being approved resource within their fellowship programme. Again, delighted to be sharing and networking with their colleagues. I'm absolutely delighted to be using Twitter again, and it's hashtag HISConnect. Please use that throughout the call. And as you'll see at the end, we're keen to keep the dialogue going throughout 2015 in between our meetings. And just a big shout out to the QI Connect team, Jennifer Graham, who you heard earlier on the call, coordinates the whole event. We have Carmen Forrest, who do all the registration and the administration and certification. Remember, all of these calls are certified for CPD. And also Rob Stewart, who keeps all the wheels moving here during the call. So thank you very much to the whole team. And thank you to Michael Kellett. I know the format is that we'll hear from a speaker and then we'll have one key questioner, and then I will put the rest of the questions that you put into the chat box to our speaker. Michael is the Policy Director in the Quality Unit here at Scottish Government. Delighted that Michael has asked the first question. Michael's a trained solicitor who's got more than 20 years' experience working in government in Scotland. The Quality Unit leads on strategy and policy for the health service with a strong focus on quality and improvement. A perfect segue in to talk a little bit about our first speaker today. We're absolutely delighted to be able to start 2015 series highlighting the global reach of Ko Awatea Connect. Connect across more than 12,000 miles and 8 time zones to New Zealand. We're 13 hours ahead and it's currently 10 PM on Tuesday. Their Tuesday has already gone. Ireland is dealing with many similar challenges to those facing us here in Scotland, with the blessing of an ageing population, the multi-morbidity and the opportunities of health and social care integration. Here's Dr. David Grayson. David is a head and neck surgeon at Middlemore Hospital near Auckland, and he's also the clinical lead for the design and delivery team at a groundbreaking innovation and improvement centre called Ko Awatea, and you'll hear more about that in a moment. And he's just to share their experiences of driving and supporting health and care improvement in New Zealand. David.
Thank you, Brian.
Thank you for joining this session just before bedtime, local time.
And it's still 23 degrees.
It's about 23 degrees Fahrenheit here, so you're
about even.
Over to you just now, and welcome to Ko Awatea Connect.
Thank you very much. Now, am I getting the ball from you, Jennifer? Oh, yeah, I've got that. Right. Okay. Well, thank you very much. Talofa, kia ora. And that is about 3 ways of saying hello in New Zealand. As you may or may not know, we have a large population of Pacific Island people, and as well Indigenous Maori. And so we're very conscious of their needs and acknowledging them. So thank you very much for inviting me, Brian, and it's great to be part of this, and thank you actually for adjusting to do things on time. So can I just check, are those slides showing okay for you at your end?
Yes, David, thanks.
Great, okay. So, yeah, so I am very privileged to be giving this presentation for you, and I just thought I'd give a brief overview of what we've done so far at Ko Awatea, explain a bit about what Ko Awatea really is about, and hopefully, and then I'll talk a little bit about, because you're specifically interested in the work we did of running some campaigns. The first campaign we ran called the 20,000 Days. I'll go into a bit of detail around that, and then hopefully we'll have plenty of time for lots of chat and questions. Does that sound all right?
Thanks, David.
Great. So I entitled this Quantum Collaboration, and it was because we have seen an awful lot of really fantastic collaboration going on, both with our District Health Board, our hospital area in South Auckland, which is Counties Manukau is the area. But it has been collaboration as well across the country, and obviously with events like this and with organisations like yourselves, has really helped us to bring all this together. But I like the description of quantum because I'm very, very keen on all the ideas and teachings of Richard Feynman. And you hear that I just hear lately or recently that his famous lectures have all come online. So I'd encourage people to check that out. A brief introduction on New Zealand. So our health system, we're a population of about 4.5 million people, and our particular area, as I mentioned, Counties Manukau, which we serve, is one of these district health boards. You'll see the infographic in the right-hand corner where it's split up into 20 district health boards, which really each health board is responsible for the population that resides within that area. And we're largely a publicly funded system. There is a small contribution of private medicine. We have, and in particular areas such as ours, a large proportion of our population is very high need. So that's a real significance for us. Interestingly, I remember when I spent some time with the IHI a few years ago, I spent a sabbatical in Boston, and John, who I did some work with on the claim that he had done, mentioned he thought how New Zealand's, because he wanted to find out more about New Zealand's health system, and I sort of told him about it, and he found out about it. He thought that it was most, of all the different systems he had come across, he thought it was most similar to Scotland. So it's an interesting idea. We are actually probably fairly similar in a lot of respects. So we have, certainly, as you mentioned, all of the problems facing us, and that was really the reason for the development of our Quality Improvement Centre, Ko Awatea, and it was in response to all of the pressures, and in particular for us in our area was this huge demand and growing demand for hospital beds. And one of the big successes that we achieved through doing our campaign and looking when we started out our 20,000 Days campaign was to think in terms of the whole system, and we were really conscious that the important determinants of health are not actually from within health but outside of health, and so this whole cross-sector collaboration is very much an important thing for us, and we actually have a government policy on that called Whana Ora, which actually is a Maori expression which translates as meaning well families or healthy families. And this has been an interesting development because the idea and the concepts behind it are in terms of getting all of the government departments to be thinking and working closely together, but the actual practicality of doing, and particularly sharing funding, has proved a bit problematic. But it's going along pretty well. But at least we were doing our work in the background or the context of this happening across the country. A lot of talk about this. So our hospital was pictured there, and you'll see on the right-hand side there the photo of the entrance into our main reception. A little window, perhaps not clear to you, but that's featuring welcoming expressions in a whole host of languages. And we have, I think, around about 80 or 90 different languages spoken in our particular district health board. So we do have quite a few challenges with a vast number of different entities, and also we're perhaps probably one of the poorest areas in terms of the actual incomes for our people that we serve. Livermore Hospital is the big hospital. It's about 800-bed hospital, and we provide some tertiary services, but a lot of the tertiary services for the Auckland region are in the central Auckland part of Auckland City Hospital. Was started back in 2011, and it's my story, the background of this. So we had this feeling that we wanted to the capability for doing quality improvement to help all of our frontline workers and deal with the challenges that we're facing in all sorts, not just within the hospital but outside of the hospital, in particular around, as I was saying before, with cross-sector work. So forming this centre was really perhaps the brainchild of Grayson, who is our CEO, who's Welshman, and he had the support of our board, and at the time the chair of our board was VP, Costa, and he's now moved on, but they were right in behind this idea and concept of developing a quality improvement unit within our district health board, and certainly a first for our country, and quite a challenge really, because we were sort of setting ourselves up as quite a consultancy type approach to serve not only our own needs, other needs of other organisations around the country. But anyway, the name Ko Awatea means the first life, and it refers to that day, and signifies all the potential of good things that can happen for the day ahead. So that name is actually gifted to us by our local Maori Kaumatua, who are our elders, Maori elders, and so it's got a good significance for us, and very proud of it. The slide here is just demonstrating the big range of work that's gone on in terms of trying to build up our capability, and it follows the Kaiser Permanente approach for how you're trying to develop capability for doing quality improvement right across the board. So we started off with a strategic partnership with the Institute of Health Improvement, so that helped us a lot in terms of providing a whole range of courses and classes that staff could do. And the great thing about the partnership that we have for Ko Awatea was that it was developed in conjunction with the 3 local universities who train all the different professional groups within healthcare, so medical, nursing, allied health. And so actually the cost of the building is shared, and the real thing is that it provides a place where all of those professional groups can congregate. So we have all the students coming through, and they mingle with frontline healthcare workers. And it's not sure how many of you have actually visited us, but it really is a very attractive setting. It's got a nice big cafe area in it. So that's a really successful thing about it, that it's this joint venture partnership with the local training universities. 2,000 Days campaign came about, as I mentioned, because we were faced with this problem of the growing need for hospital beds, and our public health physician done some modelling, and they were forecasting out the increased number of bed days that we would need if nothing changed, if we carried on doing what we were doing. So that was the sort of the pressure, or the platform, if you like, to force us into taking on this challenge. And so we had done through this modelling, that's how we came up with the 20,000 number. That was the prediction for, I think it was for 2 years ahead, that we would need 20,000 more bed days. And the thing in terms of setting all this up, there was an awful lot of consultation and engagement of all numbers of staff, as well as our local community. And it was a group of community patient advocates that we had, who in an advisory role for our district health board. They said, you can't go out there and call this the 20,000 bed day campaign. Nobody will know what you're talking about. And they convinced us to reframe it as returning healthy days to them as community members, which was such a nice way to put it, and helped us a lot in terms of getting buy-in to contribute and be part of things. So you see on the left there is one of our poster boys, as we call them, and this is one of our patients who really benefited from the work, as I'll explain a bit later, from one of the teams that was working in this campaign. And the thing I'll just mention at this point is, so we had decided that we were going to run this campaign based on the IHI Breakthrough Series Collaborative methodology. We'd had IHI helping us to expand that and teach that in different groups across the organisation. But the challenge for us was that we weren't, we had done work across the country doing the central line infection, and that had gone really well. But it was a different sort of situation where we didn't actually have a set of interventions that we knew we were going to have to do. We tried to do a really good literature research and work out what it would be, what were the things that would help with the bed days, but actually we couldn't, decide. That was with all our various experts. There was a great deal of clarity around what actually would be, gold and give us the gold apple. So we set this up a bit differently in that we really going to all of the various groups, the difference around the hospital and primary care and the community, and saying, what is it that you think, you would like to change from the way things are currently happening, and at least test that as an idea that you're actually going to make a difference. I think that was a critical thing for getting a bit of buy-in for it, that we're giving people the license to actually test ideas that may have wanted to but hadn't really either had the funding or the ability to do for whatever reason. But it was a huge uncertainty, and it was quite nerve-wracking coming into this and being appointed as a clinical lead. And I certainly have to acknowledge Dinah Dowdall, who some of you will have met because she's visited your early years work that you've done there in Scotland. So she's been the campaign manager, and certainly she had fairly tense, nervous times, just not really knowing what was going to happen as we went along. As I say, we had a lot of people involved. We tried our best to get this wider cross-section of people, but in the first, so we started out with our first campaign over 18 months, and it was still mostly hospital groups. There was certainly some primary care and community involvement, but went on to our next phase, which was called Beyond 20,000 Days. We shifted further out and got much more involvement out in the community, which was great. Just our first driver diagram that we had, and it was just really pretty basic. And it's quite funny because I was showing these slides to Diana today, and she was commenting on how far we'd come, really, because we look at this now, we think that it's actually probably a little bit too simple. But anyway, that was our first good go at trying to just work out what we thought were the primary drivers, and then what changes that all the different teams that had come to us with ideas and who want to go ahead and get going with trying these different interventions. Some of the idea of the saving of the 20,000 days interestingly came about in terms of when we were explaining it. I had been at one of the IHI forums, and Don Burke was talking about the Sotolo's work in environmental work, and this concept of if you're actually going to try and reduce the carbon loop, that it's not going to be one thing, it's going to be multiple interventions. These features shift from this increased growth of, in this case, carbon, coming to at least stabilizing it. That was how we were trying to explain our desire. Here on, this was our predicted growth in bed days that had been done based on the modelling work from our public health physicians, and painted in the same way that we were going to at least stabilize it, which you'll see from this from the graph that we've been able to do so. This was the dashboard we had from when the campaign finished, and but it has actually maintained carrying on. And so we put together this dashboard to try and this was one of the biggest successes actually, was to encourage our whole organisation to get used to data in this way, which obviously now know that you're doing all of your work all based on using statistical process control charts. It's just a big difference for how we used to work. We used to all be sort of anecdotal and people's opinions and all the rest of it, and have huge sort of meetings that were going forever complaining and moaning about things. To change the way that the whole work of doing our work was done just by introducing these sorts of charts. So you'll see some interesting things that we had with the presentations to the emergency. We basically were on a steady growth pattern for that, but during the course of the campaign, we noticed that that started to drop off. And the big thing too, again, and it was quite helpful for us, we knew that it wasn't just solely the work that was being done within the campaign that was contributing to all of this, because across the hospital there was such a focus on trying to improve the system that we always had to acknowledge that a lot of the other work that's happening happening that wasn't directly within the campaign, because these were overall sort of whole system measures we were looking at, would be contributing. But that was quite challenging, trying to sort of fend off people that were attacking us, if you like, for what we were doing. So with the benefits that we saw from running this campaign, it was just a great way to really focus people and, as I say, to give them the chance to actually test some ideas about how to change things. But interesting stuff really was this idea of people working together. We had examples of like a general practice. So we had two general practices in the same building, but they never, until they got involved in this campaign, they had never actually even met each other or talked to each other, because Thinkers, in the same as your system, our primary care, they're privately owned businesses, and sort of tend to compete against each other. So it's fascinating for us to see that there were these relationships developing across the whole organisation. As I mentioned, definitely this whole improvement that we had in terms of developing the capability to analyse data, but also to be able to act on it as well. And we just see there was just again using the methodology of the model for improvement, and the methodology was so helpful in terms of focusing people and our learning sessions, and then the work going on in between. And some things, so obviously I presume you all will have done the Mr. Potato Head exercise at some stage. I remember actually Jason Leach, I'm not sure if Jason's on the call, but I remember his presentation. I think that was in Paris, about how to run a Mr. Potato Head. And Diana's son actually painted these Mr. Potato Heads as gold, which we gave out as awards for some of the teams that had done really well as at the end of one of our learning sessions, which was quite fun. And I think, and we certainly acknowledges Brandon Bennett was the improvement advisor who helped us a lot with the work, and he mentioned Urge's photograph to the guy that actually had invented the Mr. Potato Head game, who thought it was quite a hoot. So a range of the work that was done is shown in this slide, and this is actually we had some teams, but these are the teams that then went on to implement their changes. So some didn't carry on because their ideas didn't work for whatever one reason or another. But some of the most successful ones certainly were these ones named here. So the VHIU is very intensity users, and these were people that were turning up to the emergency department, and we'd arranged a flag system that if they turned up after a certain number of times, then this team, which was led by Professor Harry Ray, and Harry's one of our physicians who really fits the bill of what Maureen Miano mentioned as the new roles of clinicians or people working in healthcare as extensivist. So he's a specialist, but he really spends most of his time out in the community, out in people's homes, out in primary care. He's just fabulous, and he's our professor for integrated medicine. And so he led this team, and they would be, once these people were, they'd go out and visit them in their homes, and they'd have pharmacists as part of their team who would check all medications, which was often part of the cause of the mix-up and problems. But also that was where a lot of the intersectoral work would happen, because obviously visiting the homes, they'd be able to pick up on all the social issues and make the right connections with the social services. And the SMOOTH, which stands for the Safer Medicine Outcomes and Transfer Home, was led pharmacists, and I'll have more information of that in a minute, but they did a fabulous amount of work in improving, and that required getting more results in terms of more pharmacists, but it was definitely demonstrated as a good sort of business decision because of the savings that they made so great. We had a whole range of interventions that were across the board, and it was a kind of an interesting mix of things going on, but pretty hard to keep track of, really. So this for the SMOOTH, the team, so they developed their change package, and they were focusing on the improvement of identifying and correcting the pharmacy on the wards and before discharge, and able to identify areas as part of that. They calculated that they saved 520 days in the 12 months of their work, which was pretty impressive, and that was really good detail. And they were the example of some of the teams that were able to really identify the bed day savings. Some of them, because it was so mixed up and so complex, they had an idea of perhaps how many they might save, but it wasn't perhaps quite so clear. As the packages that they had developed within the pharmacy team, and on the side here is all of the years that they had tested and little signals, and this is one of these neat things that they developed to help themselves identify work that had been successful and which was going on, or work that was dropped off, so they could keep track of all of the different parts of their work that they're doing. So the various of users, they really were very successful in terms of this idea of keeping people out of hospital, or at least when they were discharged from home, really connecting up with all the services that were required, and particularly linking back in with primary care, because often for our population, they just felt that, well, they would treat the hospital as the only source of medical care, and wouldn't really think of going for primary care treatment. And so part of the work that this team did was to reconnect people with a GP, or even set them up with a GP if they didn't have one. So as Ko Awatea, as we've been doing a lot of this work, we've branched out to helping, as I said, other organisations, and so we're now getting involved along the lines of your early years work. We're working in education, particularly around early education, and this is following the same, using the model for improvement and collaborative methodology, helping to get young children into early learning centres, which historically our area, again, for reasons, there's not a huge sort of intake, even though it doesn't cost for children to attend. And then there's been big move around well children, and doing our whole, we have a commissioner for health, and the Ministry of Health have a big focus in terms of having the whole approach to the management of healthcare for young children, as all of them, bringing in other services, and that's bringing them in under the context of the Aurora policy. So that's a very brief, quick sort of overview of some of the work we've done. I'd at this really like to invite all of you, obviously, but as many as that can make it, perhaps to visit us. We have a forum which is much like the IHI forum, but obviously not as big, and that's coming up in September this year, and anybody who is interested or would like to find out a bit more, and likewise find out more about the work we've done, feel free to contact me, and we'd certainly guarantee you'll have a good time. So that's it for the moment, Brian. Shall I hand back to you?
Thank you very much for that, David. That was a tremendous overview of the work that's going on there, and very many parallels and similarities with some of the work that we are working on up here in Scotland. I'm going to invite Michael to join the call. How are you doing, Michael?
Brian, thanks.
Over to you. What do you think? And you have a question for David.
Great. First of all, thank you very much indeed. I didn't realise you were a whole 10 hours ahead of us, so it's kind of approaching bedtime. It's very much appreciated. I just thought make you feel better though, we're a whole 24 degrees behind you. I was 13 hours behind you, because it's one here in Edinburgh. I can't speak for colleagues elsewhere in the country, but hopefully that makes you feel better. David, that was fantastic from our perspective, and Ryan says there are huge parallels with the work we're doing. So I'll kick off at a kind of general level. As you said in the presentation, and as we know from an IHI colleagues, In order to enable transformation and improvement at a large scale, we need three things. We need will, ideas, and execution. And I want to kick off by concentrating on the first of those, will. And so the question is, how did you go about making the will to accept the need for transformational change in your system and to the creation of Ko Awatea as means to catalyse that transformational change? I based in that building of will at a number of levels, amongst leaders in your system, amongst clinicians, but also amongst the politicians, your politicalising environment, and also clearly around patients, families, and the public you serve. And also say something about that building of will, specifically around the 2000 Days campaign, as well as generally. Very grateful.
Michael, thank you. So this, as I said, was Ko Awatea started, and this work really of the 20,000 Days campaign started around 2011, and so he had been going through that whole global financial crisis, and also in addition in New Zealand, we'd had the terrible earthquakes in Christchurch, which a huge impact, obviously, but also had an impact nationally in terms of so much resource and funding had to be diverted to support a ongoing sort of rebuild and cope with all of the damage that had happened down there. And so that the effect, like across on a national level, of real action, actually pretty much being driven a lot by our politicians on this whole idea of there is no more money, and any money that there is going to be diverted to support Christchurch. So there wasn't probably too much problem in terms of getting engagement, the level of the national level, or the attention, if you like, of our politicians. That anything that was going to improve the pending fallout of us collapsing under the weight of hospital full days sort of thing would be was always going to be appealing to the politicians. So with locally, we had the situation too, where, as I mentioned, we do have a large proportion of very high needs people, and we've got very high rates of obesity, and along with that diabetes, and so we have, what's regarded as third world illness. We have still had high rates of rheumatic fever, which makes us quite appealing for medical students to come and visit. But that's really in our local situation or scenario. We, as well as just the problem of managing from the bed days point of view, it's from a general health perspective. We knew we just couldn't keep on going on in that same life. So that was really the burning platform that came for us. And so the idea around setting up Ko Awatea was because there was a lot of talk at the time and to set up an actual quality improvement sort of center for the country, and that eventually morphed into our own quality commission, Health Quality Safety Commission, and they've been a significant partner with us in doing a lot of the work and helping to fund a lot of the work. But for us locally, it was the idea. Grant felt that great to have something at a national and sort of more in the ministry or that sort of thing, but still there was a pressing need in our own local DHB to have an actual frontline response that was capable of dealing with this. And so that's really what led to that idea of the formation of the quality improvement at Ko Awatea. And so for being able to get the will around that was obviously a lot of championing of the ideas of improvement, but the key Ko Awatea was this mix of having the education involvement, so that helped to bring in the whole teaching and research alongside it, and so it was, and it's been a really successful partnership with the three main universities in the area. And so far as getting our clinical involvement, I think we've been lucky in terms of we do have a lot of physicians, and certainly no problem with us in allied health are always key for getting involved in improvement. but I think we've just tapped into a lot of keenness to make this better, because I think interesting, we have the type of people that like to work in our organisation. Sort of, they're always interested to do that because you know that you're doing serving such needy population. That's have some rub off on us. I think that we actually really deal with a lot of pride in what you do. So we had the sort of, we had an evaluation, an evaluation set up for looking at all of our work, and the that they used as part of that was they felt that we were pushing on an open door, that our organisation, our community was ready for this, and do have a lot of very amazing input from our community in terms of volunteering, and so all the sort of right ingredients were there for us to be able to take on something as challenging as this. I mean, we've certainly by no means bothered at all. We're still having problems with hospital fulls, but we've managed to stabilise things, and we're shifting all the time closer to the action is in the community and this whole idea of the cross-sector work. So I think that's really what we've been able to at least achieve is a mindset shift, if you like, to really getting closer to really building and working on actually developing health rather than just focusing too much on the back end of health care.
Michael here, thank you. That's hugely helpful.
David, thank you, Michael. Now, David, throughout the call, you've a whole host of comments, and first of that was Drew Henderson, who I worked with you in Hawke's Bay.
I saw that.
Yeah. So Drew's consultant renal physician in NHS Tayside, and he was just making the point that when he worked with you in Hawke's Bay, he thought the health systems were fairly similar, but the degree of health and social care integration provided by the District Health Board were greater than ours, and certainly he experienced less problems in the transition of patients transferring into ongoing care. Would you have a view on the relative degree of integration that you have there compared to here or elsewhere?
I'm not too sure on your situation, but can I just check, because I was checking with Jonathan Gray, our director for Ko Awatea, about things, and he mentioned that is Tayside setting up a quality improvement unit. Is that right? A bit similar to what we've done here?
Yeah, well, NHS Tayside have for a number of years now had their for organisational effectiveness that has some similarities with Ko Awatea. Yeah.
Right. Yeah. So yeah, I think interesting, and I think this we need to say about the whānau, because it's really driven on that whole concept from which is so good to have, which has come out of the whānau aura, and that specifically really was aimed at trying to help from Maori perspective, our indigenous population, because they get caught out so often because view on health and their approach to things can sometimes be quite in contrast to otherwise European or white view on the world. And so it's really, this sort of trying to actually deal with the important things for them and how things are to be done with, because they certainly want to be in control of the way that they manage their lives, and so they quite often, do come unstuck in our system. So we've been helped by having that at a policy level that's driving it, but it's a real challenge because you have all these different groups and organisations having to, at least be willing to share some funding or give up some funding for another part of the system to take it on. There was a wonderful example that's often used. You may have come across it. So we had a big drive to improve the insulation in the houses. New Zealand housing is, particularly publicly provided housing, has historically had really terrible insulation. And so we've had a big drive to improve that. And it was so successful in terms of helping us in the healthcare system that the Director General of Health at the time actually released some of the funding that was allocated for health to the housing ministry, because they had actually helped to save. So the drop in the presentations and admissions for respiratory illnesses just was dramatic once the insulation improved. So it's that sort of mindset, that will help people, give up some precious dollars for some other part of the system to carry on.
Thanks for that, David, and thanks for the comment, Drew. A number of other comments. Ewan Morrison, the Director of Pharmacy at National Services here in Scotland, said it was great to see a focus on the quality of reduced medication errors and also the subsequent reduction in medicines waste, worth noting for all healthcare systems. And Julie,
I think I'll just make a comment, because the pharmacy people, they really get quality improvement like nobody else. That's been our experience. They've been fantastic. Because I think they, obviously within their systems are so used to the deal of quality, but they've been such an inspiring bunch, and particularly our lead pharmacist, Sanjoy, has worked so well with the community pharmacists and helping to hand over a lot of, information and expertise, so that it's not just held within the hospital setting. So our community pharmacists are right on board. So we've been really fortunate in that regard.
That's a way into the comment and question from David Maxwell, who's an improvement advisor here in Healthcare Improvement Scotland in our Scottish Patient Safety Programme Primary Care, and particularly focusing on working with community pharmacists. And
right.
David mentioned that it was good to hear about the SMOOTH initiative with the elements of medicines reconciliation. He was keen to learn a bit more about engaging the working relationship between secondary and primary care. You might comment on that, and we'll direct David to some of your resources as well.
Yeah, well certainly. Certainly also would have to acknowledge the work that you've done in the primary care, the patient safety. So Neil Houston, we've been very fortunate to have come out and help us replicate the collapse that you've had there in Scotland. And that work is largely, focused around a lot of it is focused on management of particular medications in primary care setting. But it's that sort of work, and I think also we're going to see these, as Maureen had mentioned in her at the forum, it's just this changing roles, and I think in my specialty as an ear, nose, and throat surgeon, that it's our role as doctors to support those other members of the team, so that they don't have any fear of come stuck when fingers are pointed if something goes wrong, that they're going to be backed by us. We've been able to have a really successful service in ours, having GPs of the special interest, and nurses in our team doing a lot of work which is otherwise would have to be done by us, and which we have no way of coping with the load. So I think that's the critical bit there, is that support that comes from, particularly from doctors, to be supporting other members of the team in all sorts of ways.
Thanks for that, David, and thanks for the link to the work of the SPSP programme. And very pleased that Jill Gillis and Neil Houston and the team are able to work with you to share. A comment here from Patty Webster, who's an improvement advisor at the IHI in Denmark. Patty's made a number of comments, but one of the questions was were community members, patients and families involved in creating the fast driver diagram that you showed earlier in your talk?
Which they I'm not quite sure how to name this article. It's very basic. It's sort of one of those just about done on a napkin sort of thing. Not specifically. We had a lot of input. Particularly, we had big engagement events leading up to the launch of the campaign, and certainly involved a lot of patients, had patients and community members. So that was really helpful, though, in terms of helping us sort of our thoughts around just what we're going to do and areas we're going to focus on. And we had a list of DRGs for admissions to the hospital, and which helped us to focus on which were the critical areas, the most number of bed days that were being used. And the interesting thing in that was that the top condition was cellulitis, skin infections. And it was intriguing because it wasn't necessarily on the radar for a lot of us. And actually, I mentioned John Whittington. When I told John Whittington, he thought that was just bizarre. But then he actually went back and had a look at the American data and discovered that cellulitis was right up there as well in the reasons for admissions in American hospitals. So he had no idea. But so it was certainly helpful, though, in terms of our engagement sessions that we had to actually get the input from the community because they certainly knew. And it was a challenge, again, this challenge for us. Although the pressure point was in the hospital, we wanted to try and work across the whole system. And so it was pretty hard, but quite worth the effort for us to convince the community and the primary care as well, obviously, that this was actually important to do. So it was kind of an interesting experience doing that.
Yeah, thank you. We have a question from Pat Tyrrell, who's the lead nurse in Argyll and Bute CCP. I was interested to know more about the very high intensity users. How did you identify that group of patients, and how do you develop the new roles required to intervene?
Certainly, we could help in terms of detail of that, but basically it started out that they were patients who would turn up, they'd have, with a time frame, and I think it was within a year, they'd have 5 or more presentations to the emergency department, and then that in our IT systems, we set it up so that would raise a flag, and then that would lead to then basically a phone call to the team, and subsequently, the members of the team who are pretty much within the emergency department as well, right hand to take on, and then basically though what would happen was then would mean that patient would be set up to have a visit from this team, and the makeup of that team had been really, that was the work that Harry's done with setting up the whole goodness of nursing and community nursing, pharmacy, and also, but the critical bit was always linking in with the primary care providers in the patient's area that they were identified with. But that was what we were really trying to do, was get that link and get them better supported in primary care.
A question from Jacqueline Thompson, who's a nurse consultant in older people in NHS Tayside. To you from the wonderful NHS Tayside Improvement Academy, she says. Do you have any evidence or data doing advanced care plans or holding do not resuscitate discussions early in the patient's trajectory makes difference to bed days? Yeah,
that wasn't actually a specific part of the campaign, but across the country a really big focus on advanced care plans. So I couldn't turn off that connection with the bed days, but not just that it would do, but I would really check and see.
Yeah.
The other thing wonder, you might have noticed, there are pretty strange sort of names for these collaborative teams, like Smooth and the VHRU. The suggestion from the community was that we needed to get more sort of day terms, because we had one group called Better Breathing that started out as COP or something, and of course everybody thought, what on earth was, unless you were medical and knew what it was. So that was quite a cool suggestion, and so all the teams then changed their actual medical title to a much more sort of interesting name, whether it was an acronym or something like Better Breathing. It was quite nice, really.
Yeah, thanks, David. Andy Andrew is Network Development Lead at the Joint Movement team in Scottish Government. She would like to ask, how are you sustaining the networks and the relationships needed to do?
So that's really been a big focus for us, and it's been a combination of still having ongoing contact with the teams doing the work. So the ones obviously that have implemented and are going on, they're still being supported. So each of our teams had a project manager. Project managers, had 2 or 3 teams each, and so we had improvement advisors who were trained up, done, through with the help of the IHI, we've trained up a number of improvement advisors. So they're in direct contact, obviously depending on what their needs were. Again, this was the interesting thing. Some of the teams became so, self-sufficient in terms of doing the improvement work and all the data and analysis. It was just fabulous to see. And then we've held other things, so trying to cover the whole thing, and we've found that's where we found Twitter really useful, actually. So the social media input has helped to carry it on and keep going, and also all of the teams have presented or had posters at our APAC forum, and so that's been another way. So multiple sort of things to keep the conversation going, if you like.
The final question from Nigel Hart, who's Associate Director of Northern Ireland Improvement Agency. Thanks for the question, Nigel. What activities or measures help to enable primary care workers and specifically GPs' involvement?
That's a really good question, because that was such a big challenge. As much as we wanted to get particularly GPs sort of on board, involved, they're private business owners, so any time spent, particularly like attending a learning session or coming to be involved in things, was time money for them. So we did, we acknowledged that and had some systems and something available to be able to either pay them directly or backfill. But certainly a lot of goodwill has helped at the very outset of this. Was also set up with a sort of like a executive group, which involved all of the primary care leaders. We have the primary health organisations in New Zealand who oversee primary care practices, and so in our district we have PHOs, and so we had their leadership buy-in, and they're all GPs, a lot of them. So their leadership in the primary care was actively, buying into this as well. But the actual nuts and bolts of getting people on the ground was certainly pretty difficult. But we made enough.
Thank you very much. We have run out of time. I'd like to just thank all of our participants today, and also to all of the folk who chatted in with questions, and indeed the ones that we couldn't get to. And big shout out to Kathy Binters from Australia. Nice to see you on the chat box, Kathy. Sorry we couldn't get to your question. But that was a wonderful call, wonderful chat. Thank you so much indeed. And we look forward to continuing and strengthening our links on a go-forward basis. Very much.
Absolute pleasure, Brian. And I'd like to, if you can, I'll say it, chat and do my best to answer some of those questions in more detail.
We'll do that. Thank you very much indeed. Thank you to David. And just a shout out for the next QI Connect. We have Beth Lilja from the Danish Society of Patient Safety joining us, 23rd of February. Beth is one of those passionate speakers about involving patients and communities in improving quality and safety. Please dial in for that. So just to show you the rest of the list of the blow your socks off speakers that we have for 2015, we'll run through them in detail at the beginning of the next call. And finally to say, please follow us on Twitter. A big thank you to Ken Miller, our Head of Communications, and Stephen Ferguson, our Communications Manager, who will be working with us this year to further spread the word about QI Connect. So thank you all. Have a great day, everyone.